Good evening, everybody, or actually good afternoon or good morning, depending on where you are. We have an extremely good turnout for this webinar. My name's Simon Ramshaw. For those of you who don't know me, I'm Managing Director for Erchonia Lasers Limited. Based in the UK, we are a subsidiary organisation for the US-based manufacturers, and we look after Europe, the Middle East, and Africa. I've been involved now with the Erchonia laser since 2012, and I had to take this opportunity to come on this call to introduce Martine, because we have a UK manager now, but Lunula will always be my baby. It was something that I launched in 2012 into the UK markets, and now we have over 300 clinics around Europe. And this leads me on to an introduction to the lady who you'll probably see to your left, Martine Silverman, who was Abraham's when I first met her. I wouldn't have been able to do what I've done with Lunula if it wasn't for Martine. Martine was the first in not just UK but Europe to have Lunula laser. She bought 8 in total. They've treated way over 7,000 patients, I think, now with laser from their London and Hertfordshire based clinics. And she's just been an absolute world of knowledge and education for me, who had no experience in the podiatry or dermatology type backgrounds before I got involved with this. So I owe a huge debt to Martine. And you will see from this webinar how much knowledge Martine does have, that she's built up over the years. Since they started London Nail Laser Clinic, they started with a 1064 nanometer laser. Before moving across onto Lunula. So Martine's responsible for all of our education and also our training programs, because there's really, I don't think, any patient conditions that she or her staff haven't seen. And we obviously, we always like to share that with our customers. So before I introduce you, I'd like to just point out on the right-hand side, you'll see a questions section. If anybody has any questions as we go along, just type them in there. And then after Martine's finished her presentation, we'll put the questions across to her. We think it'll probably last around an hour in total. We appreciate a lot of you have your dinners to get and what have you, as does Martine and I. But yeah, we hope you find it as useful as what I think you will find it. So without further ado, I'd like to introduce you to this marvelous lady who is the lead podiatrist and director of the London Nail Laser Clinic, Mrs. Martine Silverman.
Okay, thanks. All right, that's quite a lot to live up to, so now I'm a bit scared. Okay, hi everyone. I'm just going to play a little bit with my, there you go, my computer. So, thank you all very much for joining us this evening, and it is evening in the UK. I'm going to kind of change for those of you who have either had training by me or spoken to me. I'm kind of hoping that you're going to learn something new today. I'm quite passionate about nails, which is a really weird thing to say and kind of quite sad. But actually I really am, and as time goes on with Lunula, I learn more and more myself, and there are a few things that I have realised over the past 10 years, but probably not over the past 10 years, over the last couple of years, I would guess, that when it comes to nails, it's not rocket science, but actually as a podiatrist, and I qualified in 1996, so quite a long time ago, I realised I didn't really learn very much about nails. So what I would like to do today is just go through a little agenda. So what do we treat? How do we treat? And should we always use Lunula to treat? And in that is a little bit about nails, a little bit about the Lunula, and a little bit about the patients, the results, clinical studies, stuff like that. So as Simon said, please type your questions. He'll see them, I won't, but then I will hope to see them afterwards. And let's get going. So what do we treat? Well, we treat both fingernails and toenails. Now, I say that as a podiatrist in the UK, That's what I'm allowed to do, pathological fingernails, pathological toenails. The device itself, Lunula, is cleared with FDA clearance or approval for the clearance of onychomycosis. So that's fungus. However, I'm in the UK and not in America, and I know that we have the European kite mark. I know it's safe, and when I treat patients, fungus seems to be a very small part of the problem that they have. So most patients will come to me and say, I've got a fungal infection. They don't all have fungal infections. We'll see as we go through the presentation. I've got a few photos with different things that I have treated over the years. So we also treat skin. Now, it's very rare that someone will come in and they'll have a problem just with their skin, but the majority of patients I see who have had fungus, either an acute infection, in which case they've probably got acute athlete's foot or tinea pedis, or a chronic infection, in which case they tell me they have very dry skin, but moisturizer doesn't help. That's because they've actually got a chronic fungal infection. So let's look at nails first of all. And what's a nail? Well, it's a very hard thing that sits on our digits, on the edge of our digits, and it has evolved from a claw. Now, we don't need claws. Humans don't need claws because we don't climb up trees very often, and we don't dig holes with our fingers or our toes. But what's happened is over the years, this protective protein cover has evolved slightly, and it means that we are able to pick things up, whereas some animals, most animals, aren't able to. Primates can. It's really important to know the structure of the thing that we're actually treating when patients come in to see us, because without that knowledge, what tends to happen is you expect things, you expect certain results, and they don't happen. And it's taken me many years to really work out the process that tends to occur, the healing process that tends to occur, in order to get really nice nails for my patients so that they are happy again. My objective as a podiatrist is to give my patients a healthy nail area. So the live tissue that's there needs to become healthy so that the dead nail plate that sits there can look a bit better. I'm not a pedicurist, manicurist. You really wouldn't want me painting your nails. I don't make nails look pretty, but by virtue of the fact that I treat the area, and this is presumably what you all want to do too, or you do already do, you make the patient less embarrassed about their nails. So let's look at the nail structure. So we have the lateral nail fold sitting, and we have the nail plate in between the two nail folds. Our underneath nail plate is your nail bed. Now, I'm sorry if I'm sort of preaching to people who know this very well, but what I have found, so I've come across during training or while supporting practitioners, providers who use Lunula, that actually they're not entirely, they know that nail plate is dead tissue, but they're not entirely sure really what we're trying to treat. And we're not trying to treat the nail plate. Nail plate will do whatever nail plate does, dependent upon the health of the live tissue underneath. So the really important part is the matrix. So going back, that's at the edge here, somewhere around here, a couple of millimeters down, or a millimeter or so down from where we can actually see. And the matrix is where your nail cells come from. Nail cells, the keratin, very similar to skin. Keratin's the same as hair. Once it comes out of the matrix, the cells tend to die off as they lay on the nail bed. But the matrix is really important, because if that gets damaged, then you really are screwed. It means that your nail plate can't come out, your cells can't come out and lie properly. So the thing that keeps the nail matrix healthy is your proximal nail fold. So going back to the area here, you've got your proximal nail fold, which is made up of the eponychium, which is really the end bit, and the cuticle, which is actually a see-through or clear layer of dead skin, really. So the eponychium is live tissue, but the cuticle is dead tissue. Now, the problem that a lot of my patients tend to have, particularly those who come to me after having a pedicure, is that they have a fungal infection under the proximal nail fold, and that's usually because the pedicurist has pushed that cuticle back, something that shouldn't be touched at all. Cuticles can look after themselves, and they are purely there to stop fungus, bacteria, any foreign objects getting underneath the proximal nail folds and into the nail matrix. So the nail bed, as I said, is underneath the nail plate. And then you've got the hyponychium. The hyponychium is otherwise called the free edge of the nail. And what that does, it's where the nail plate grows, the hyponychium stops anything from getting under that end. So when we look at different types of nail fungus, and I'm not going to go through all the types today because when we use Lunula, we're treating all of them. But different types of nail fungus, the most common is called distal onychomycosis. So that often gets in through that hyponychium, through the nail plate there, and then gets into the nail bed that way. So let's look at damage. You can't get onychomycosis unless you have damage to your nail plate. It's really simple. Nail plates which are stuck down onto the whole of your nail bed without any damage at all will be pretty much watertight, will not be able to get any kind of microorganism underneath it. It's there, the area is healthy. However, once you get damage, you then have a port of entry for fungus to get through, for bacteria. We see carinichial infections, we see lots of things going on. Damage can be done in many ways. So you have acute trauma. I saw someone on Monday who was trying to stop an intruder getting into her flat, and she kept slamming her front door, and she didn't realise that it was her right forefinger was actually in the front door. And fortunately, whilst she damaged it and she ended up in hospital, she didn't actually damage it to such an extent, this was a year ago, that it's not fixable. And actually her nail is starting to grow back. I carried out a first Lunula treatment to try and heal that damage for her. It's rare that people have acute trauma, particularly on fingernails. You tend to catch them in a drawer or a door. Toenails, you tend to drop something on them or trip over and bash them. Chronic trauma is far more common. Chronic trauma happens to us all, usually as a result of footwear that doesn't fit us properly or our feet move about in it. We damage our nails all of the time and our toenails, fingernails much less so. But with chronic trauma, you get a build-up over many years, and eventually you get fungus in there because there just happens to be the right environment for fungus to thrive. All nails will probably have some fungal spores on. It's no different to fungus in a shoe, fungus on the floor, fungus on the door handle. That's not an infection. However, fungus getting into the live tissue can then activate and become an infection. And that tends to happen with a lot of my patients, and probably a lot of your patients, after years of trauma. And they don't realise they have the trauma until it gets to the point where the fungus then takes over and causes a problem. Damaged nails occur with increasing age. Our nails dry out because we don't get the oil secretion from the nail bed that we have when we're younger. Our health deteriorates, our circulation gets poor. We get stressed, not necessarily as we're older, but generally through life. And all these things tend to add up and can cause problems. Grey nails, and I'm going to show you some photos later. What I have come to realise is that when I see most of the patients that I see who don't necessarily have a fungal infection, but certainly have damage there, the whole area, everything looks very grey. And it's only after carrying out treatment that I start to see the pink that we should be seeing returning to the area. Lifted nail plate. When you damage your nail, it lifts, nearly always, because it cracks in it, part of it will lift. When you get fungus there, that itself will lift much more of the nail plate. And once you've got a lifted nail plate, you've then got problems, because you may not be able to file it clear. You may have a split that keeps on going, particularly if the damage occurs towards the proximal nail fold and possibly under there. So any cells that are coming through don't have a healthy nail bed to sit on, which means that all that's going to happen as the nail grows up, it's still going to have the same split or lift in it. When we have a lifted nail plate, which is more than just a split, you then get real problems with the nail bed. These are the things we're looking to heal. So damage plays a really big part. I see a lot of ridged nail plates. Often the ridging starts off as little lines of fungus. You see it underneath on the nail bed when you debride the nail. And when that starts to heal and you start to kill off any fungus there, you see the little ridges go, which is really good. And everything smooths out a lot. So fungal hematoma, bruising. I saw someone, and I'm going to show you a picture that I took, a few pictures that I took when I saw her on Monday and from the time before. This is a patient of mine who is actually running up Mont Blanc on Friday and running back down it. And she's been doing really intense training over the past few months, and it's really wrecking her nails. But you'll see that actually nail regeneration, because of the Lunula, is really helping her even at this stage when she's damaging them on a daily basis. Those lines, Erchonia, things that we see all the time. When you wear shoes that don't fit you, what tends to happen if you walk downhill and your nails start to push into the toe box of your shoe, you get Erchonia, you get the nail plate pushed back into the nail fold. That then creates those lines, it causes problems, and you can then end up with a nail bed that doesn't lie flat. Shrinking nail bed. When you have a nail plate that's not stuck down onto the whole of your nail bed, what happens is that nail bed will start to get smaller and smaller, but at the same time it will start to get higher and higher, which means that any nail cells coming out can't sit flat on the nail bed because the nail bed isn't flat. That then means that you've got a thick nail. That thick nail gets more and more damage because you have less and less space in your shoe. And when that happens, you get more problem and you get fungus coming in. So onto the fungal involvement. Excuse me. There's fungal spores everywhere. I said before about them being in shoes, being on the floor. We don't know how long they stay alive. Some fairly old research, there were a couple of studies done, thinking about the 80s or 90s, and one showed that spores stay alive for a couple of weeks, one showed that spores stay alive for 18 months. It's anyone's guess. I personally don't swab things. I clean things, but I don't swab them first, so I don't know how long fungus stays alive for. However, we do know that you can get fungal spores in shoes, you can get fungal spores in socks, you get fungal spores just sitting on your nail plate. You know, they're nasty little things that once they get in and they activate and they cause an infection, they take a long time to go, and you have to have the right treatment for that to help. So when you've got your portal of entry and you've got your fungal spores going into your live tissue and thriving, your body will try to get rid of them. And our bodies produce something called hydrogen peroxide, H2O2. However, we don't tend to produce enough to get rid of the fungus that's in our cells. What tends to happen is we produce some, but we need just added help, and that can be with nail fungus, with athlete's foot, with ringworm, with candy, with thrush, spot rot, all these different fungal infections that we get. When you get a bacterial infection, we also produce hydrogen peroxide. It's bleach, it's antiseptic, it gets rid of antimicrobials, but at the same time, our bodies will raise our temperature to try and kill off the bacteria. It can't do that with fungus because fungus starts to get broken down over 50 degrees, coming up to about 56 degrees. And when your body gets to 56 degrees, you're dead. So that's not going to happen. So we need to try and find something else to help us. And traditionally, the things are drugs, either topical drugs or systemic drugs. But they don't tend to help so much. So you'll see how Lunula deals with getting rid of fungus by using hydrogen peroxide. So keep damaging nails, problem gets worse, the environment increases, chance of OM. A lot of patients nowadays, I've been a podiatrist for over 25 years. Whilst I saw a lot of nail fungus back in the day, I'm seeing a lot different now. People tend to either work in offices where they're in structured shoes all day, but now offices will have heated floors, so their feet are getting hotter. Our central heating is better than 40, 50 years ago. We go to the gym more, we tend to be a lot warmer. The environment is better for fungus to thrive. The shoes that we wear are certainly not particularly great. A size 5 shoe is still a size 5 shoe in length as it was 10, 20, 30, 40 years ago, but in all likelihood that size 5 shoe is a lot narrower, less material, the toe box will be shallower, the whole shoe will be a lot narrower. So we also don't get our feet measured really once we reach adulthood. So we're wearing shoes that are the wrong size, but we'll talk about that a little bit later. But our environment for fungus in our toenails is really favourable for the fungus and not so much for us. When it comes to fingernails, probably about 15% of the patients that I see have fingernail problems compared to the 85% who have toenail problems. However, out of that 15%, maybe 80% are fungal involvement, and often that's from wearing nail varnish or gardening, having hands in water, doing lots of washing up, having jobs which require your hands to be wet all the time. I see builders who use cement a lot, potters who obviously use clay. It's the environment there is much less favourable to fungus, however, still possible, sadly. So I've spoken a bit about nails. Skin, I see people with skin problems as well. So hands and feet, whilst similar in structure, are usually in very different environments, which means that when I see patients with fingernail problems, their skin is more often than not absolutely fine. Whereas when I see patients with toenail problems, their skin is more often than not pretty flaky, sometimes very acute athlete's foot and quite itchy, quite red, has some various issues in there. So it's things that we need to be looking at and considering when we're looking at what treatments to do. The blood supply is obviously different. With our toes, we don't really get a great deal of blood supply because we don't use our toes in the same way that we use our hands. Our hands, we do much smaller movements, so the muscles there tend to create, build up, particularly if you're right-handed, your right hand will, left-handed, your left hand will, so you get a better blood supply. Also, with our hands, they're often out in the open a lot more, and when we wash our hands, we tend to dry them better. A lot of people, when they wash their feet, have a shower, they get out and just pull their socks on, don't really dry the area, so we tend to have less damp hands and more damp feet, so nice environment for fungus. But when it comes to the blood supply, we have a better blood supply in our hands, so that means that damage can heal better, and less blood supply in our feet, so damage is slower to heal. We also look at autoimmune issues, psoriasis, eczema, allergies, dermatitis, things like that that can occur, and we need to look at how the involvement in the nails is connected to the skin involvement. So when we have a patient who comes in and they have athlete's foot, the likelihood is by the time they come to see me, they've got involvement in their nails and they just keep on cross-infecting backwards and forwards. And they will often tell me that, they use Lamisil, they use Dactyl, they use all this stuff. Their skin gets better for a while, but their nails don't get better. Their skin gets better, they stop using the cream, their nails reinfect their skin. With eczema and psoriasis, it's a slightly different kettle of fish. And whilst the nails can be affected, when we start to see psoriatic nails, you've got your damage there, which means that fungus can get involved. We can then heal the area temporarily, but you can't stop psoriasis from coming back, or we can't stop it. There are various treatments for psoriasis, but more often than not, at times of stress or flare-ups, the nails will become affected again. So a much shorter term solution. So let's look at how we treat. Traditional treatments, we all know about Vicks Vapor Rub, mouthwash, vinegar, bleach, all these different home remedies. I couldn't possibly tell you how effective they are. If you look on Facebook, on certain groups where people say, oh, I've got a fungal infection in my nail, how should I treat? You'll have a whole load of people saying, you must put Vicks Vapor Rub on, you must put tea tree oil on, you must put this on. It will definitely get rid of it. What tends to happen by using the home remedies is you get a lightening in colour of the area. So it looks as though the fungus is being treated. It's unlikely to treat in the long term. Topical preparations, over-the-counter ones, prescription preparations are fairly similar. Whilst you've got a nail plate there, it's difficult to get all these topical solutions into the nail bed where we actually need them. So sometimes when you've got a lifted nail plate, what actually happens is you do get topical preparations in, and it keeps the infection at bay. When I see patients who've had, or report they've had an infection for 10, 20, 30 years, what actually happens when I'm looking at their nails is there's no clinical signs of an infection, but they've used various things over the years. So they may have taken the systemic medication, they may have used topicals, everything that they could find at home, abroad, over the internet. And actually what's happened is the fungus tends to get to a level where it doesn't spread anymore. You keep it at bay, but you've still got the damage there. And what they think is a fungal infection is actually damage at that point. So they've actually helped themselves. So I think that topical preparations, whether they're home remedies, more so probably drug preparations, actually do have their place. And I don't have, for me, I treat with Lunula, which we'll speak about soon. But if patients use topical preparations and they find that they help a little bit, that's great as well. And the same with systemic medication, so Lamisil, Sporanox, all different ones that are around. The reason that patients don't like to take them is the side effects. The reason that I don't like to advise patients to take them is the side effects. I see people in clinic every day and they tell me how ill taking their terbinafine made them, or how they couldn't drink anymore, or how they didn't want to take it because they had to have blood tests for liver function. I wouldn't take systemic medication for a fungal infection. I'm lucky I have Lunulas, I don't need to, but I wouldn't anyway, because I just think nail infections tend to be cosmetic to a certain extent until they become medical much later on. But by taking systemic medication, if you suffer from the side effects, then you've got an illness, you've got a systemic problem. And usually it does go when you stop taking the medication, but I don't like being ill, and I don't think many people do, so I certainly wouldn't advise it. So we then move on to something a little bit more drastic, nail removal. It rarely works by itself. Take a nail off, it will start to grow back okay. Within a few months, you'll have a problem. You've got a nail bed that's exposed, and in all likelihood, because nails do take a long time to grow, you'll get more fungus there, which will be trapped under the new nail. There have been cases where nail removal does work and somehow you don't have any fungus, and perhaps it's the nail isn't actually infected, it's just damaged, so you remove it, new nail grows through, and it seems to work, but it's unlikely. Nail removal with phenolization, where you then have no nail, is an absolute no-no. If you have no nail growing from the matrix, you have nothing. You can't put a nail reconstruction on, it won't last very long because you'll still have oil coming from the nail bed. You can't use Lunula to magically produce some nail tissue because it just doesn't work. You can't take systemic medication, that's not going to do anything either. So anyone who comes in and wants a nail removed and phenolized, you really have to tell them it's a bad move. Thermal laser. So when I started off at London Nail, when I started the company in 2009, I bought the pinpoint foot laser over from the States into Europe, and it wasn't as effective as I would have liked it to be. The small amount of research that had been done said it was about 77% effective. That was actually only on, I think it was 17 or 19 nails, and in actual fact, there's no way that pinpoint was 77% effective. It was about 50% at best. And the reason that thermal lasers are not as effective as non-thermal lasers is because they hurt. When you're using a thermal laser, you're increasing the heat to the area, so you're trying to create an environment that kills off the fungus that's there. Thermal lasers are destructive. They don't treat damage. In fact, they often damage more if you're not careful. So for me, I hated using them. I used them for 3 years and then fortunately came across Lunula. And in fact, I came across Lunula before it was even launched. And then it was kind of launched as I bought mine and Simon started selling to other people. So really, thermal lasers can be dangerous. They can create all kinds of problems and they're not particularly effective and they really hurt. And if you treat using them, you have to say sorry a lot, and I hate saying sorry. So it was never a good thing for me. The other treatment would just be ongoing podiatry treatment. Well, it won't kill fungus, but it certainly will keep damage under control. And that's something that I use along with Lunula. I'm a podiatrist. I find it very difficult to look at a nail and not cut and file the nail, not do something to it. You know, it makes me laugh when patients come in and they've cut their nails that morning. And I was saying, oh, you're taking my work away from me. You know, but I'll still manage to do something there. So what's Lunula? Well, it's a class 2B device. It is incredibly safe. Hot lasers, thermal lasers are usually class 4 devices, and we'll look at the electromagnetic spectrum in a moment and I'll show you where both of these types of devices sit. Low level laser is becoming more and more common for so many different things, and my belief is very much that it will start to take over, laser therapy will take over from traditional medicine, surgery, things like that over the years. Lunula has 2 laser beams, 2 diodes. They rotate. When you look, you can see on the little picture, you can see them both. The colours aren't particularly clear, but you have the violet 4 or 5 nanometer beam, that's your antimicrobial beam. That's the one that gets your body to start breaking down the fungus. And you've got your 635 nanometer red beam, and that's the one that gets your body to start healing that damage that's there. How it works? Well, low-level laser therapy stimulates healing. It's no different to going and standing out in the sun and you take the rays of the sun and they make you healthier, which is why certainly in the UK we're not very healthy from about mid-September through to about May, because we just don't get enough sun and therefore we don't get enough vitamin D. So the 2 diodes work at the same time. When you use a Lunula, if you can see 2 light beams, you know it's working. That's really all there is to the Lunula. When your body starts to take the light into, we have things called photoreceptors in our cells. Certain things will happen in our cells, and I'll go through the cascade of events where chemicals are produced in a minute. But essentially, light is like Lunula is light therapy. Laser is an acronym, and the L in laser stands for light. We need light to live. We need light to stay healthy. We need light to heal. Lunula is light therapy in its most simplistic forms. And when I talk to my patients and tell them that it's light therapy, a light goes on in their brain. They go, ah, yeah, I'm a lot healthier when it's nice shiny sunlight outside, I feel much better. This is going to make me feel better too. So the visible light spectrum is the little bit in the middle here that you can see. Infrared is what thermal lasers use. UV light is sunlight. The higher the wavelength, the more heat you produce. So whilst UV light is sunlight, the sun is a ball of fire. That's where you get the heat from. The actual rays of the sun themselves are not actually hot. The UV light shouldn't really feel too hot, and that's what we're looking at. As we go up the spectrum, you get more heat. Down the spectrum, you get more energy. So wavelengths of 900 nanometers or higher are class 4 devices, and they tend to be infrared once we get to 1,000 nanometers or so. And visible light is in between UV and infrared. So when we use the Lunula, we have our 405 nanometer, which is right near UV light, and we have our red laser, which is right near infrared. The visible light actually just initiates that physiological reaction that we want, where the chemicals are made that then get your body to heal. Lunula itself doesn't kill fungus. Lunula itself doesn't heal nail damage. The body does that itself, but the Lunula tends to get the body working far more efficiently than it does without it. So the photochemical reaction, you've got your Lunula here, your 405 and 635 nanometers, which start to activate the photoreceptors, which result in a couple of different responses. So reactive oxygen species and adenosine triphosphate are things that are the primary response. That's what happens once the light is taken into the cells. Once you've got those, they're converted into hydrogen peroxide, bleach, and they ATP into nitric oxide. What nitric oxide does is it dilates your blood vessels in the area. So when you use a thermal laser, there will be a depth of penetration where for that depth, that 3 or 4 millimeters, you get the laser into there and you get an increase in heat. That doesn't work the same way with Lunula, with low-level laser like this. What happens is the cells take the light, they take the energy, and at some point there won't be any more to take. When we use Lunula, it actually has a slightly systemic reaction. So it's not just the toenails, it's whatever is in the box, whatever cells are there going where the Lunula beams go round, tends to take up this energy and converts it to these two chemicals that we need. So when we use Lunula, the reason that we use it is because we want to enable the body to eradicate pathogens, and we also want to stimulate healing. So when you use the 405 nanometer diode, you're getting an increase in hydrogen peroxide. When you use the red 635 nanometer diode, you're getting an increase in blood supply. When you get an increase in blood supply, you're also getting more hydrogen peroxide in the area because you get your immune response happening. So, protocol. Well, I'm going to tell you that I stick to a very loose protocol myself. Now, there's a lot of studies that have been done using different protocols from, I think, the early days where I think the first study was just 2 laser treatments, 2 Lunula treatments, and going up to one which I'm going to show you briefly in a minute, which was 4 Lunula treatments a week apart, and then an additional 5 treatments up until 14 months. So the way that I treat is for toenails, I carry out 4 treatments. The interval between those treatments will depend upon what I see, but the 4 treatments for toenails are kind of my minimum, and then I use the Lunula later on as required, depending on the response of the patient. When I carry out treatments for fingernails, I do 1 treatment and then I will review, because fingernails do tend to react a lot quicker, and actually I don't feel that they need 4 treatments. As far as I'm aware, all of the clinical studies and trials have been carried out on toenails only. So anecdotal evidence on fingernails, so what I see in clinic and what other people have seen in their clinic, shows me that they tend to respond faster. So how far apart would I do the treatments? Well, and this is really rare, if I see a very new acute active infection, then I will start off treating weekly so that we try and get as much hydrogen peroxide as possible. I don't know how long the hydrogen peroxide stays in the body for. However, when we look at the red beam, the nitric oxide, the effects of the red beam can last about 6 weeks or so. So what I'm looking to do is get a balance between treating the fungus that's there and treating the damage that's there. What I found is if you've got a nail that's damaged rather than infected, leaving 2 months, even 3 months between treatments actually seems to give really, really good results. Now, there is no study that's been done on this as yet. I don't really tend to do research. I tend to treat as I find appropriate. I changed my protocol to leaving longer in between treatments, really sort of post-COVID. So before COVID, I would try and carry out the 4 treatments between a week and maybe a month in between them, depending on my availability, patients' availability. When my clinic was shut at the start of COVID for a few months, I had told all the patients who were in the middle of their 4 treatment package that don't worry, they'll get worse, we'll do extra treatments, we'll deal with it, no problem. What I saw when they came back to clinic was really different to what I expected to see. And there were various reasons for this. The first reason I would expect is that people weren't obviously wearing shoes quite so much. We had a nice warm summer. They weren't going to offices quite as much. They weren't running up and down escalators at the tube. The shoes that they were wearing were probably more open-toed, so they weren't damaging the area. But also, I think nails just grew a lot better. And part of that is that in the summer, nails do grow faster because we have an increase in blood supply because of the sunlight. And in the winter, we don't tend to have that increase in blood supply. Our blood supply goes to our vital organs more than it will go to starting to heal damage with your nails. So my general protocol is pretty much dependent on the patient that I see. And what I've realised over the years is that people who think it's black and white and that you must do 4 treatments and you must do those 4 treatments 1 week apart will not necessarily get the results that they would like to get. You have to think outside the box a bit. And when I carry out training, this is the type of thing that we go through. So is this set in stone? There is no protocol for me that's set in stone. Well, it's no different to taking paracetamol when you've got a headache. And this is sort of, you know, something that I say to my patients, that everybody is different. I and they could both have a headache or wake up with a headache. We both take our 2 paracetamol tablets at 8 o'clock in the morning. I then go back to bed, you know, have a few more hours sleep, wake up, have a coffee, have something to eat, have a fairly easy day. They go off to work, have a really stressful day, don't really have time to eat, certainly, you know, don't drink enough water, don't have a rest. When it gets to 12 o'clock, I'm fine, my head's great. Theirs isn't. They're feeling really sore, they are feeling really tired, they need to take more paracetamol, you know, they try and do whatever they can do. A lot of drugs, lasers, medication, everything depends on the person. We're all different, our bodies are different. So protocol is not set in stone in my clinic. And I can see from, you know, providers who send me photos and, you know, do different things, that actually protocol shouldn't be set in stone. Clinical studies and trials are there for a couple of reasons, and we'll go on to that now. There's so many decades of research into low-level laser therapy, all different wavelengths, frequencies, you know, different things that they treat. It's out there, it's on PubMed, it's all over the internet, you can find loads. But for me, I'm not really that interested, you may have realised, in research and clinical studies. I'm interested in what happens in my clinic, and my patients are my priority. However, I do have to base how I treat on research that's been done. So if it wasn't for research, there'd be no FDA approval or CE mark in the EU for safety and efficacy. So clinical studies form the basis of how I treat. I then take it a little bit further. There have been lots of studies across the world into Lunula, and they all have their pros, they all have their cons. So for me, inclusion and exclusion criteria are a pro and a con. So the pro of them is that something that has been excluded from a study that shows safety of a device means that I will exclude it from treating from patients. So pregnancy is a prime example. I won't knowingly treat someone who's pregnant because I just think I can't 100% say to them, yes, it's low-level laser has been proved safe. Lunula has had studies done on pregnant women and therefore it's safe. I can't say that, therefore I won't treat. However, when we get into inclusion exclusion criteria of things like patients who have taken systemic medication in the 6 months prior to treatment, that to me is irrelevant, because if it's excluded from a study, it's not excluded because it may not be safe. It's excluded because it may warp the results of the study, the efficacy results. So I'm not worried about that in clinic. If I have a patient who's actually taken systemic medication without side effects, I'll tell them to continue, because I like to throw everything that I can do that is safe at the problem. Lunula is a part of what I do. It's a tool that I use. It's not the only thing that we use in clinic. So the other issues I have with clinical trials, protocol, as I've said, my protocol isn't set in stone, but in a study it will be, because that's what you're looking at. And that's fair enough, but that doesn't necessarily equate into real life clinic. I don't treat all my patients the same. Quite often clinical studies are quite small subject sizes, and they're there sort of to prove a point. That doesn't happen in clinic. I can have any number of patients coming in that it's only limited by the amount of time that I have to treat. If we were to look at the results that everybody who uses Lunula throughout the world has got, we'd have enormous studies, but they would all be on different protocols and things, so it doesn't quite work like that. Quite often, or pretty much always, clinical studies are checked by external unbiased professionals. That's a good thing. You want people to look and say, actually, we don't necessarily believe that, so we want to go back and check it. That gives us a little bit more to fight with when people are skeptical. Input from drugs or manufacturing companies in clinical studies are a con, as far as I'm concerned, because actually, if you have, if you're biased towards what is being studied, it's not necessarily a good thing. However, I do recognise that companies have to get the studies done, they have to sponsor things, they have to get things done. So that's fair enough. This was, as far as I'm aware, the last or the latest sort of published article for Lunula. I may be wrong, but this was published in January 2021. It's a treatment of toenail onychomycosis using laser pharmacology. Laser pharmacology, read Lunula for that. So Kerry Zhang is a podiatrist out in Arizona in America. He actually, I believe, has been using Lunula for the longest, in terms of he carried out some very early research. He did various different things using Lunula to prove how good it is, using Dopplers after Lunula treatment, before and after Lunula treatments, to show the increased blood supply. He has trialed, all different protocols. So this this article that was published was, again, quite a small subject, 20 patients. They were treated for 4 weeks, one treatment each week, And then they had 5 further laser treatments later on. Now, they got great results with this. In my clinic, I do the 4 treatments, not necessarily weekly, but after the 4 treatments, I will then carry out treatments as required. So my protocol isn't as rigid as this, but I would say that pretty much every patient that I treat gets an improvement. And whether or not they get a mycological cure, I don't know, because I don't take samples, we don't take cultures, and we go purely on clinical cure in clinic. So the clinical cure in this study shows a lower percentage than the mycological cure. But when I'm treating patients, not all of them have a positive fungal. In fact, very few of them will have a positive fungal culture, because I don't take samples, because I'm carrying out the same treatment for each patient in terms of we'll do 4 treatments. And previous studies have told me that's a pretty high rate to kill off a fungal infection. But for those who don't have a fungal infection, we're looking at what we can see in front of us and how things are progressing and how the areas are healing. So with Lunula compared to terbinafine, so compared to topical antifungals, oral antifungals, it shows us that the Lunula actually is giving a better result pretty much than the other things that we use. However, when patients come to us, the figures don't really matter, because most patients have tried all the different traditional remedies. However, they haven't got the result that they want. So they're coming to try something else. And this something else is something which is pretty much without risk. So here are just a couple of the patients that were treated during that research study. And, photos were taken over a 14-month period, and you can see that there's an improvement. What I see here is, and this is where I'm not that keen on most clinical trials, because a lot of them don't have the severity, the longevity that patients who come into clinic have with their either infections or damage. So they tend to be more superficial, and they show some fabulous results, a very nice clear nail at the end of the trial, but that's kind of where it stops. So I'll show you some before and afters from real life clinic, not just from a study, in a moment. But why Lunula? Well, there's so many reasons. The efficacy is one reason, of course, but actually having used hot lasers, the no pain or discomfort is probably the biggest seller for my patients. A lot of them come to me having had 1, maybe 2 treatments with thermal device somewhere else, and the real problem that they have is that it hurt so much they didn't want to go back. Here they're happy to come back however many times it takes. There are no negative side effects, so you don't have liver toxicity that you might have with taking terbinafine tablets. You don't have plume inhalation that you might have with a thermal device. It's not destructive, it's actually the complete opposite and stimulates healing. You don't need to take cultures, because you're not going to not do treatment if a culture comes back negative. When you prescribe a systemic medication, really you should be taking a culture and basing it on the fact that it's a positive culture and there is evidence of fungus in the area. Taking a culture, there's 30% negative rate, which means that a lot of people don't get treated when they could be being treated. They could be treated. So with Lunula, there's no need for culture. We can use Lunula on neuropathic patients because they don't need to tell us when something hurts. When you use a thermal laser, if the patient is neuropathic and they can't feel pain, there's a very high chance that you're going to burn and create really big problems. Same with diabetics and those with peripheral vascular disease. There's problems when you're using something that's destructive, when you're using something that stimulates healing. Having patients who have circulatory problems or various other issues going on, actually means that we are getting a better effect for those problems, even though that's not what your patient came in with in the first place. It also treats the entire nail area and in fact beyond. When you use a thermal laser, you tend to be treating the actual nail plate area or the nail bed. When you start to treat the matrix, you have a problem because you start to burn the area, and it doesn't actually necessarily get rid of the fungus that is sometimes there. It's not always, but sometimes there. Also, Lunula doesn't interfere with any systemic medication, so we can use it. Doesn't matter what the patient is taking, that's not going to cause us a problem. So why wouldn't we use it? Well, I said about pregnancy before. I'm fairly sure, probably 99.9% sure that it would be safe in pregnancy, but pregnancy is for finite amounts of time. So I would just wait. Also, when patients are pregnant, their immune system is looking after a baby. You don't need a new immune response in their toenails. It's really not an issue. And in fact, by the time people are heavily pregnant, they can't see their toenails anyway. So it's really not a big deal. Immunosuppressed patients. So I do use Lunula in some immunosuppressed patients. So if their immune system isn't that compromised that they're ill all the time, they pick up every bug going, etc., I will try Lunula, but it is very much under the, with the understanding that we may not get a good result. It won't make things any worse, but it may not make it particularly better, and certainly not in a great, quick period of time. So when you start off using Lunula, there are things that you should look out for. When you've been using it for 10 years, over 10 years, like I have, you can become a little bit more cocky when you use it, I suppose, because at the end of the day, I'm treating with the light, and I know it's not going to cause a problem. And as long as my patients don't have expectations of treatment that is really going to cause them, anxiety when they don't get the result that they want, then I'm prepared to try. So it's not, don't use it because someone's immunosuppressed and it will cause a problem. It's don't use it when someone's immunosuppressed because you probably won't get a great result. New scarring. Light can actually make scars darker. So if someone has got some scarring on the area that I'm treating or the area that goes into the Lunula, I would probably want them to wait a year or so, because then it's not going to cause darkness of the scar, particularly keloid scars. Photosensitivity, whilst we're not using UV light, I suppose there is still a possibility that they can start to get a bit of redness, a bit of a rash. If you do use it on someone who has photosensitivity, just follow up with them a little bit later, make sure all is okay. I wouldn't use Lunula on someone who wants a quick fix. Oh, I'm going on holiday in 2 weeks' time, so quick, can you do 4 treatments and my nails will be perfect? It doesn't work like that. You need time to heal. I tell patients that when we get to 18 months, if I'm not seeing a far healthier environment, then I'll worry. I never get to 18 months without seeing some change, some positive change. So it is a case of being realistic that you can't have a quick fix, and things do take time, but we'll get there in the end. Risk factors, non-compliance. I haven't really spoken that much about risk factors. When I see a patient for the first time, I ask them a whole load of questions. Quite often when I ask them things like, what do you do for a living? Do you work? What do you do? Sometimes they look at me like, well, I work for a company. I'm like, okay, are you in an office? Are you this? Are you that? And I say to them, I'm asking because I'm looking for risk factors. If you wear shoes that are structured shoes for work and you sit in an office where you've got underfloor heating, that may be contributing to it. If you're sitting there for 8 hours a day, your feet are hot and sweaty in a pair of shoes that don't let them breathe. If you're a runner, that can be obviously a big risk factor. There's a whole load of risk factors where I would treat patients, but I would educate them first and point out to them before I start Lunula treatment that these are your risk factors. If you're going to continue running, and I never tell people to stop running, I don't run myself, but I understand it's very good for you. But if they are using, if they're running and I can see that, you know, they've got one nail that's a problem, I'll suggest that they use a gel toe protector, start to take the pressure off, that they go up half a size in shoes. Shoes are probably the biggest risk factor that we have, and that's because we don't get our feet measured once we stop growing in our teens, late teens, early adulthood, whatever. However, our feet do change size. They may not change length, but they certainly change width as we put on weight, as we, you know, we bulk out as we get older. A 20-year-old male, even if, you know, they stick to a good diet and they're healthy and they do exercise, is going to be bulkier when they get into their 30s or 40s, 50s. Their feet are going to collapse and be wider. So I recommend that all my patients start to look at their footwear. And I had a patient in this week who said to me, "Oh, I don't think my shoes fit me. I saw a friend at a couple of weekends ago, and he said to me, 'Oh, I've got a pair of size 10 trainers. Do you want them? I don't really like them. They're brand new, but I, you know, haven't got time to take them back.'" And this patient who's a size 9 shoe said to me, "I think I might be a size 10. They are so much more comfortable. And when I put my size 9 trainers on to come to see you this morning, I realised that actually they don't really fit me very well and my toes reach the bottom." So, you know, looking at the environment that patients put their feet into, their hands into, is a thing that's going to actually help because we educate. Reinfection. So again, that goes back to environment. You know, patients who might go skiing 18 months after, you know, a year after they've had their Lunula treatment, and they wear ski boots that they hire, in all likelihood, they're going to end up with damage, more infection, unless they are educated and they know what to look for. So should we always treat? No, we shouldn't always treat. I, you know, say to my patients that I'm not a bums on seat clinic. So, you know, I have a great device that helps patients, but it's not always appropriate to use it. You know, the younger and healthier you are, the quicker you're going to see results, and the better those results will be. If we look at the risk factors and we can't get away from them, and, you know, we know that they're just going to happen time and time again, we may not want to treat. There are limitations to treatment, and, you know, there are expectations of treatments, and we have to meet the expectations that our patients have. And actually, Lunula as a treatment has to meet the expectations that I, as a clinician, have. And I'm, you know, I see patients who have been somewhere else and they come in and say, "Well, you know, I went for my free consultation and they told me, 'Oh yeah, you know, 4 treatments and absolutely we'll get this sorted.'" I don't do free consultations because my consultations are proper appointments of an hour long, where I sit with patients, we talk about things, and we make a decision together how we're going to go forward. That doesn't always involve Lunula. Probably 90% of the time it might do, but it may well involve Lunula a little bit further down the line. I want patients to be absolutely sure that this is the way they want to go. So those expectations. Well, Lunula's an adjunct treatment and we need everything else. You may well get a really good response early on, and often I do, and then it slows down a little bit. Patients need to know that. They also need to know if they come and have treatment sort of, you know, spring, summer, they're going to get a quicker response because naturally you have a better blood supply there than if they start their treatment November, December. These are things that we discuss at the consultation. You know, you need to get the nail area healthier. You know, I don't tend to talk about nails. I talk about nail plates, I talk about nail beds, nail matrix, nail area, which encompasses the whole lot. And you can't have a nice looking nail plate if you don't have a healthy everything else. The nice looking nail plate comes right at the end because it takes a long time for regeneration of the nail bed mainly. Damage can occur again at any time. That's something patients need to know. You know, 2 steps forward, a step back. Depends on what shoes they wear, where they're going. Are they going on holiday? What are they doing? Are they running up Mont Blanc or whatever else? So, you know, all these risk factors. Healing doesn't happen in a completely linear fashion. And there's likely to be peaks and troughs, improvement, regression. It's no different to going to the dental hygienist and having your teeth cleaned, and you come out and you eat food and you drink. You might brush your teeth and floss, but there's still going to be a build-up of muck there that you wouldn't have straight after you've been to the hygienist. That's what life is. It carries on pretty much for all of us. And if you're going to create damage, we need to outrun the damage by using Lunula. So when we get to the end of the 4 treatments, we then go on to a review program where we review in clinical by photo, and we deal with whatever happens at the time. If I carry out further Lunula treatments, I don't do another load of 4. I'll do 1 at a time and keep reviewing. So there's not always a noticeable appearance change. Sometimes that happens much later, but actually patients come back in and you debride the nails, then you often will see a change in appearance at that stage. There's fungus everywhere. It's very easy to reinfect if you get the damage again, or in fact, even if you don't get new damage, whilst healing is occurring, you've still got a fragile area. So you need to be really careful, and that's where things like antimicrobial sprays come in, or creams come in, shoe sprays, washing socks at 60 degrees. We do a lot of educating, a lot of advice, and an aftercare package that patients tend to go with. They tend to be very compliant when you give them the aftercare package at the end of the first treatment. Also, Lunula can't change immunity in the long term, nor does systemic medications, nor do topicals, nor does nail removal. All these things you can catch fungus. Unfortunately, our bodies don't become immune to fungus like they do to some viruses and to some bacteria. Professional nail care, I'm a podiatrist, that's what I do day in, day out. And often by doing that, particularly in thickened nails, whether they're thickened from a fungal infection or from damage, will keep the nail under control and will reduce the risk of further damage. So how we ensure good results? Well, podiatric skills, that's got to be the big one for me. Everything I think about when I look at the nails for the first time comes back to things that I've learned over the years. And actually I learn things all the time, and you have to think outside the box and look at how people walk and different things, what they're doing, in order to work out how you can go forward. Post-op sprays, reducing risk factors. Photos are an absolute must, and I'll show you some photos in just a moment, which show why they're a must. I don't remember what people's nails look like, and when they look at their nails every day, they don't see the difference. It's like looking in the mirror, and one day you need a haircut, but the day before you didn't. Good communication with your patients. If they feel that you're pressing a button on the machine 4 times and saying goodbye to them, they don't have a good service, they don't have value for money. If you communicate with them by sending out emails saying, hey, send me some photos, let's see what's going on, or by calling them, or by letting them call you. I say to patients, I'll see you in 6 weeks, but please call me before if you're concerned, or email me before if you're concerned. That's a good service, that gets good results, and I'm sure some of the good results are psychologically better than they would be if you actually really look at it. Patients are happier when they know they're being looked after. A regular debridement if required. So here's just a few. I'm not going to really, these are just for you to look at. 18 weeks, quite a superficial discoloration there. Looked absolutely perfect after. 16 weeks, it was only, probably went to about 50% of the nail bed was affected there. Lovely nail after that. This is someone who had shellac, and they were left with this because moisture got underneath. This was 16 weeks after they actually only had 2 Lunula treatments. I only ever saw this girl twice, and then I saw photos for, well, up until 16 weeks after, when I said you don't need to send any more. Looks lovely. And this was, you can see some bruising here, was damage, and then 8 weeks after the first treatment, things are starting to heal. New nail that's coming through was looking better, but it still had a way to go. So I don't often see acute OM. this was a case of acute OM, someone who was doing a 50-kilometre hike in hiking boots that he'd had for an awfully long time. Now, I actually know this guy very well. I'm a scout leader. I've known him since he was 16. He's now 30, and he has worked at London Nail in my office when he was a student. He used to come and do the filing and answer the phones. So I know him pretty well, and I never treated him when he was younger because he was a rank teenager. However, this was earlier this year. His nails, whilst they were never treated at the time, didn't really have the bright yellow patches. They had more damage than anything else. However, from hiking and still wearing the same hiking boots that he'd worn when he was 16, he got a proper infection. And this was 6 months later, having done 4 treatments, and his nails are looking much better, which was great. Grey nails I mentioned right at the beginning of the presentation, and it's something that I've only noticed recently, that these here, everything looks a lot healthier, looks pinker, even on nails that weren't affected. Everything looked greyer until you kind of used Lunula and got that blood supply up. So grey nails is, I'm pretty sure, indicative of not enough blood being in the area. There was no infection with this guy. This was a patient who actually treated his mother as well. They're quite energetic family, and both run a lot and just both have the same foot type, foot shape. His toes are a little bit hairier than his mum's are, but they both have the same problem with their hallux nails. And I've carried out 4 treatments on him, and he is due a photo review very soon. So we'll see how the nail has grown up, but you can see difference in colour. This is my Mont Blanc patient, and actually when I saw her in July for her 3rd treatment, she had subfungal hematoma. She didn't have that when I saw her a couple of months earlier for her 2nd treatment. But when I debrided, so this is pre-debridement, post-debridement, I've got rid of some of the nail that's there, but the hematoma was still present. When I saw her on Monday, the hematoma was still there, and in fact had probably got worse over time because she's done a lot more training. But when I debrided, a lot of it came off, and we both sat there quite surprised to see this lovely new area of solid attached nail that had no bruising. So what tends to happen when someone has nail damages, over time you see a bruise there, and the cells, the nail bed where the bruise is, these cells tend to merge with the nail plate because they're dead cells, and then gradually you can get rid of them. And we worked out that it probably took about 6 weeks to be able to do that. This is someone who was first seen actually by my associate, my former associate, just before COVID, 15th of January 2020. I actually carried out the 4th Lunula treatment right at the beginning of March 2020, and then of course we went into lockdown. This photo was the 9th of August this year, and the nails absolutely lovely, and actually has been lovely for quite a while. But what I want to show you is what's happened throughout that time. So from 15th of January 2020 up until the 9th of August this year, so 2.5 years really. And you can see this was, there was not much of this nail there once debrided, and this was at the 4th treatment, still a very raised nail bed and not much nail. And then this is where we started doing photo reviews. Now I have seen her just to trim her nails during time because she's not very confident at cutting her own nails, although I don't think I've seen her at all in 2022. So she has been cutting her nails there, and she sends me photos. And when she sent me that one, the 9th of August, I said, look, we won't set up photo reviews anymore unless you still want to. And she said, yeah, I really want that comfort of knowing that you're checking up on me every so often. It takes a few minutes to look at her photos and reply to her, and she's absolutely lovely. So I will continue to do so until she tells me to stop. But you can see that it goes through a real cycle in order to get the nail covering the whole of the nail bed. So, you know, it took 7 months really for that to sort of start happening. And then, you know, more months for it to start to grow over the edge of the nail bed. And then she had a bit of damage, so we got set back a little bit, and then it started to heal again. We still didn't do another Lunula. This was on 4 treatments only, and it's taken all this time until, you know, even in June there was still a little bit of damage that we could see, and in March, for it really to look quite nice. And she is absolutely thrilled, as am I. So that's where I end my presentation. And we'll start to take some questions. I just need to get us back into where I can see what's going on.
Hi, Martine. I've just had to put the light on here, so apologies for that slight delay. No, that was a fantastic presentation. I learned so much. I think it's been a while since we've done one of these, so it's been great to hear of the new protocols, or not your new protocols, but your new mentality to the protocols.
Yeah.
And I think we've discussed that previous, because some of us, I think, get a little bit too bogged down on, right, how many treatments, what's the protocol? But as you quite rightly said, you know, our body is a pharmacy, so we don't always know. We just treat each patient as an individual, and the key is to keep in regular contact with them to see how they're getting on, and then acting appropriately.
Yeah.
So let me see, this is quite an easy question. How long does each treatment take? I mean, it's quite a short one to answer. It's 12 minutes per foot. Martine, I presume you still treat both feet most of the time, even if one's infected and one isn't, or does it depend?
No, actually, I don't necessarily treat both feet anymore, unless they're, so the times that I would treat both feet would be if there's an acute infection which is spreading rapidly. Even if there's no signs on the other foot, I would treat, or if there is damage to other nails. When patients come in and they've had, you know, a problem with one foot for many, many years, and it's never ever gone on to the other foot, then I will just treat that one foot for them, unless they want to have both treated.
Great, thanks for that. And I think something else that you alluded to before, and I think, you know, we have, you know, as you know, a wide array of lasers in our portfolio, from treating pain, accelerate healing, to fat loss, reducing the size of fat cells. And, you know, final results always do depend on perception of the patient, and, you know, not misleading them, being very real with them, which you always have been, and most of our clients are. It's not a bums on seats thing. We all have hopefully the same sort of approach, which is a sustainable business model. We want our customers to come back. We want to give them the best advice that they possibly can. So that's always good to hear.
When I carry out my initial consultation, I am as negative as I can be about what will happen, because I really don't want anyone to feel that they have been misled. That's not the game I'm in. I legitimately do want to help them. I obviously have to earn money, it's a business, but I won't treat someone if my gut feeling tells me that they are not going to be happy, even if their nails are perfect. You know, you have to be really realistic. And for most patients, what they are wanting is to not be embarrassed about their nails. And once you point out to them that, you know, when they stand up and they're talking to someone who's also standing up, and the other person looks down and they can, you know, they don't see what we see when we look close up, that's what the objective is, to get them to the point that when they look at their nails from standing up, their nails look fine. They may not be fine forever, and they need to know that their nails may not always be fine, but it is really about, you know, embarrassment and trying to work out how you can help your patients.
Yeah, definitely. I mean, we have a Lunula Facebook group, which Martine runs, which we've got, I think, around maybe 100 of our clients around Europe that are on the group. And, you know, we don't just want them to put on successful results. We encourage everybody to inquire about, you know, potential treatment options, what everybody else thinks. We encourage it to be interactive. Martine obviously always has the final say on what she would think. So, you know, I think a lot of the conditions that you may come across, it's always good to speak to your peers as well, just to get some other feedback in case you're missing something. So, here is one, Martine. I have a patient who is a runner who insists on nail reconstruction as she's very self-conscious. Would the nail recon delay the effectiveness of treatment?
Okay, so I use nail reconstruction, and I, at the moment, am in sort of two minds about it. And the reason I am is because with some patients, you put a nail reconstruction on and it actually holds the nail down, the nail grows, and you take it off and you think, wow, that's fantastic. With other patients, it seems to be that when you put the reconstruction on, it stays on for a period of time, but when you take it off, the nail almost looks shorter than it did before. So I do use it. I suggest to patients who run or swim or whatever that actually they wait for a couple of days before doing it, because if they dislodge the reconstruction, that can cause damage to their own nail. You know, it's a balance between the patients being happy with what their nails look like at that point, and for some, you know, it has to be reconstruction, or, you know, trying to get the nails healed a bit better. In my opinion, occluding the nail, putting something over the nail is never going to be a great thing long term. So I will do nail reconstruction, but I will only do it a few times before I make them have a break. It's a difficult one to answer. I think what I tend to do is I'll do the reconstruction once and see how that patient's nails have fared with it, and then make a decision after that.
Okay, thanks for that. Is it beneficial to do 2 rounds of 12 minutes if only treating one foot? I know the answer to that, but I'll let you answer.
No, it's beneficial to do a 12-minute cycle, because that's the optimum that the body responds to it at. If you do another 12-minute cycle, you won't get any additional response, and in fact, you may in some cases get the body going, no thanks, not going to do that, and kind of switching off. So yeah, one 12-minute cycle is what we do.
Yeah, it's all to do with the photoreceptors responding, and, you know, throughout a whole course of different lasers, we notice that the photoreceptors will only respond for a specific period of time. If you did another treatment, you wouldn't do any harm to the patient, but it's just a waste of time.
And it wouldn't necessarily be beneficial. You know, it could stop the first cycle from actually having the benefit that it does. So when you'd have no negative side effects, but you wouldn't have potentially any positive side effects, which is the whole point of it.
Yeah, definitely. Martine, would you be happy to do an update on laser treatment of fungally infected nails for the London branch of the Royal College of Podiatry?
Sure, absolutely. Send me an email and we can discuss that.
Okay. I think you all have the email address for us. So Mayor, if you don't mind just responding to that, or if you don't, by all means, email me direct, sramshaw@Erchonia-EMEA for Europe, Middle East and Africa, emea.com, and I will forward the message to Martine and arrange an introduction. So it's no problem. Can we get a certificate for this webinar, please? Very interesting. Yep, that's no problem at all. The internal team will send something out for you. We use Novion laser 3B non-thermal 820 and 940 nanometer, which is in the infrared spectrum. Why should I change to Lunula?
Right, I kind of think I covered it actually. That visible light is higher energy and less heat, and actually, if you go, and I'm sure that the Erchonia team can send you research, but actually, this kind of light seems to be more efficient than thermal lasers and than the Novion. I know about all these lasers. I only use pinpoints. I didn't use Novion, but I have a lot of colleagues who have used various different devices, including Novion, and didn't ever seem to get consistently high results. With Lunula, I seem to get consistently high results. It has taken time for me to really get my treatments how I want them to be. And I think that with any kind of device, you have to see so many patients and see the cycles of so many patients. So like I showed you the photos of the patient throughout the 2.5 years with her damaged nail, this is what I'm seeing with patients all the time, because I have the photos, the results to back it all up. Simon, you might want to close your ears, but my loyalty is to my patients and not to Erchonia, I'm afraid. However, with all the devices that are out there, I haven't found anything that rivals Lunula. So, I can only speak from my own experiences. I don't use Novion, but I believe that Lunula shines far brighter, I'm afraid. So I changed for
a lot of it, Martine, if I can just chip in there as well, it goes back to when we were doing our research, and this goes back to the early 21st century. When Steve Shanks first got his first FDA clearance for non-thermal laser diode, which is in the visible light spectrum, red 635 nanometer for neck and shoulder pain, we looked at a range of different types of technology, from infrared, which tends to be between 700 and 1,000 nanometers. We looked at LED, and we didn't come across anything that delivered the same level of results on pain as non-thermal laser diode. I mean, it's a coherent collimated monochromatic light, and I think that's why we use LED, for example, as our placebo, because it's non-coherent light. So as soon as the energy hits the skin, it scatters. So by the time it gets to the mitochondria of the cell, you get a diminished energy load. And as you keep going up in nanometers of laser, you deliver more heat and less energy. So, when we look at the therapeutic window, and we look at visible light through the red to the green to the violet spectrum, delivering billions of photons through these line coherent rotating beams, we found was the most effective way of delivering a treatment, no matter what we're doing. We're trying to work at a cellular level here. A lot of the heating devices aren't at a cellular level. It's creating heat to try to cause trauma, to cause this fibroblast type activity. But we're making changes at a cellular level. We're affecting cellular memory. We're affecting muscular memory when it comes to pain. We're increasing circulation. So there's a wide variety of advantages, I think, of non-thermal laser diode. But it's a great question from David, because when we launched our lasers that treat pain and accelerate healing, it's Erchonia's bread and butter. They've got 20 US FDA market clearances across the board, and that's out of 23 that's been given to low-level laser, which includes infrared and includes LED. So there's only 3 US FDA market clearances we don't have. But there's a huge gray area in Europe with regard to what a low-level laser is. And a lot, even professors I've come across, don't really understand non-thermal laser diode. They can't understand how it works. I think a lot think it's too good to be true. We can treat pain, and we can treat the nerve root associated with the area that the patient's feeling the pain, which can give a significant improvement in the result. And we're doing a lot of neurological studies at the minute, and a lot of our clinics already do these treatments. And being a US-based company, we can't promote something we don't have a US FDA clearance for. But everything's going down the route of treatment at a cellular level. to try to empower the patient's body to make the changes themselves. So it's a very natural treatment. So the laser, in essence, I suppose you could say, isn't really doing anything. It's just causing this photochemical reaction to empower the patient to fix themselves. So whether that's Lunula for fungus, whether it's, I know Martine treats a lot of, general nail trauma, psoriatic nails. With our other technologies, we have a FDA market clearance for chronic plantar fasciitis. And again, it's the same sort of thing. We're trying to get the patient to heal themselves. So I hope that explanation helps. Are you nodding, or are you shaking your head, Martine?
No, I'm nodding. Yeah, absolutely, absolutely.
The next one is, how much do you charge for your treatments, Martine?
For 4 treatments, so feet, I charge £588.
And is that including the consultation, or you charge for consultation?
Consultation's different.
Right, okay, no problem. Do you debride the nails of every patient?
Unless they don't need debriding, absolutely. I would never in a million years not debride a nail that needs debriding. I'm a podiatrist, that's what I do. And if you have a thick nail, it's prone to damage. If you have a nail that's not fully attached to the nail bed, then you've got a nice little warm area for fungus and bacteria to thrive. You want to take back, we've said many times, nail plate is dead tissue. So if it's not stuck down and thin, you want to take it off. You don't need to have it there. It just causes problems.
Yeah, I agree completely. And I think that raises another point as well. And, I think with every product launch that I've been responsible for, we're trying to build a sustainable business model that will last for decades. Erchonia is a family-led company, and we've very much got that same feel in Europe, the Middle East and Africa. And the training and support given is just as important as the actual technology. If we were to just provide one of our lasers and sort of say, off you go, you'd reach a certain level of success, but you'd never optimize the performance of the laser. So we try to give this continuous support, because it's our reputation at stake, just like it's yours at stake with your patients, and that means a lot to us. So that is key. We provide the marketing collateral files because, the beauty about Martine's involvement, without embarrassing her too much, is, as she said, when she was the first in Europe to have the Lunula, and she had to do a lot of self-learning, and she's still doing that now. But the benefit of having Martine involved in our training and education infrastructure is she's in a perfect position when new customers come on board for her to discuss the experiences she has had and the knowledge she's gained from doing something different. So, we feel very privileged to have you. And I think you've been involved now 10 years, so hopefully there'll be another 10 and we'll still be having these discussions in another 10 years time.
Blimey, I hope not. I'd like to be retired.
Novion is not thermal. We use microscopy and culture and a negative result as an objective measure of a successful treatment. And this gives, sorry, I've lost the track there. This gives a success rate of about 80% after 4 treatments. Aesthetically, though, the outcomes are not so good over 1-year review, but we are thinking of buying a new machine, and Novion has packed up its operation in this country. I think you're spot on. I mean, when we say thermal, we tend to say sort of 1064 nanometer, but the higher you do go up in nanometer of laser, the more heat you deliver and the less energy. We've got a lot of published articles on the biphasic dose. We've got quite a few things that will compare infrared to non-thermal laser diode, which we're happy to share with you. But, I think at the end of the day, from our perspective, when we do a lot of these educational forums, especially with regard to pain, where, Erchonia have over 16,000 customers in North America alone that treat pain and accelerate healing, we just want to educate on the different mechanisms of action and delivery mechanisms of each technology. And then it's up to the individuals which they feel is best for their clinic. Lunula, we are still very confident to say is the global leader when it comes to treating, onychomycotic nails. But also, I think the most flexible, as Martine alluded to before. you know, the ability to treat psoriatic nails, to treat yeast and candida infections, to treat just general nail trauma. So when we first started out, a lot of our, as you know, Martine, a lot of our customers, including you, were taking nail cultures. But as time went on, I think it was you that even said that you stopped doing that because you realized Lunula worked on most things, whether they were actually mycotic or they weren't.
I think that that's really key to Lunula, is that actually it stimulates healing. Novion, Pinpoint, Cutera, all the other ones that I can't even remember the names because I don't think about them anymore, don't stimulate healing, nor do topical preparations, unless you're going to maybe pop a bit of coconut oil on, nor do systemic medications. So whilst they might be antimicrobial and have very good, you know, rates of effectiveness, you're still going to have a nail that's not quite right. And it may not have fungus in it, but it will still be damaged because all the other things can't help the body to heal the damage. And that's where Lunula comes out on top. It's kind of a no-brainer, I think, for me.
And I think with the UK as well, I think we've got over 75 clinics in the UK alone. We've got about 50 in Sweden. We've got a lot in Poland, France. So we're not pulling out anytime soon. We're trying to build a future for the company. And pulling out would mean we're not able to provide the levels of support to our clients. So I can categorically say that won't happen. Unless I win the lottery tomorrow. But then again, I'm sure the next generation of Ramshaw can come along and take over.
If you win the lottery tomorrow, share.
Yes. Listen, guys, thanks so much for the interactiveness and the questions from everybody. I think these questions allow us to give the answers based on our experience. We like to think we give the answers based on, you know, a neutral viewpoint. Obviously, we have a lot more experience with non-thermal laser diode, but with Erchonia being essentially a research and development company, you know, we don't bring anything to market that hasn't had the necessary levels of clinical research to back up the technology, which again gives you a starting point. As Martine said, study environments are different to the clinic environment, but they're to give you the confidence and reassurance that, you know, it has been tested. Nothing's come out from infrared or LED to make us think that we're not going down the right route with non-thermal laser diode. Again, it's an education, and you know, we've got quite a few presentations on our YouTube channel which go into the scientific underpinning of low-level laser, and it talks about the different mechanisms of action. We can send any copies of those webinars via email to everybody. They are on our YouTube channel if you want to go on YouTube and look at Erchonia lasers. They're actually in the pain playlist, and you'll see under scientific underpinning 1, 2, and 3, and it very much looks at the different mechanisms of action, because that's what we want to try and achieve, and why we want to get involved in university level, so that whether it's podiatrists, chiropractors, physiotherapists, dermatologists, or whoever, when they finish their studies, they've got a good understanding across the board on what's on offer, and then they can choose the best one which they feel fits into their own practice. So long may that continue. Anyway, Martine, always a pleasure. Thank you so much. Really appreciate it. There's been a couple of requests to see if they can get copies of this presentation, which I'm sure you wouldn't mind doing.
You've recorded it, so you should.
Well, yeah, we've recorded it, but it's just we sometimes some people ask.
Oh, you mean of the actual PowerPoint? Of course, yeah. Yeah, I'll send it to you another day.
No problem with that. Guys, look, thank you very much. Yeah. Thank you very much for coming on. Really appreciate it. It's 9:15 p.m. in Spain at the minute. We just arrived earlier today. The sun's gone down now. Enjoy your evening, everybody. And if you are traveling home, have a safe trip, and we'll see you all again soon. Thank you.